Rob Casquejo back in the Dermcast studios in Boston, Massachusetts. And I'm going to talk today to Dr. Chesahna Kindred, all the way from up the street in Columbia, Maryland. And welcome, Dr. Kindred.
Thank you so much for having me.
Absolutely. So you're going to speak, you're speaking here at the summer conference about alopecia. So a broad topic, but let's start by, you're well renowned for conditions, diseases involving alopecia. So why don't you give your backdrop a little bit and we'll just go from there.
Absolutely. So I'm a dermatologist that practices in Maryland, as you said, but the first to have a full service hair salon in-house for my patients.
Now that's very interesting. I read this about you and I don't really know much about the situation. I'm dying to hear about it. So we'll save that for the end. We'll talk shop and then we'll get into that a little bit because I think it'd be a great way to close it up. But go on. Yeah.
Yes, assistant professor at Howard University, immediate past chair for the dermatology section of the National Medical Association, and founder and president of Onyx Medical Association, deacon at my church, and some other stuff.
Okay. All right, great. So obviously this has been an emphasis in your career amongst medical dermatology. So let's just start by talking about the general condition of hair loss. So give me your mile-high view. How do you approach this when somebody comes in with this complaint?
My approach is probably pretty aggressive, at least compared to the average bear. So typically we do a hair loss consultation, and that's where we're not doing treatments, we're not doing biopsies. We just evaluate the scalp, take photos, and then I literally bring out a sheet of paper and I draw out the pathophysiology of the disease I think they have, starting with the normal follicle, all the way down to whether it's scarring or not. And then I separate our approach into 3 or 4 different categories: grow, things that directly make the hair grow; then wellness, which includes the salon, AI checks, our discussion group; then if it's an inflammatory disease, treatments that directly neutralize inflammation; and then finally repair, such as hair transplantation, platelet-rich fibrin matrix, etc. And this sheet of paper that I've written everything out for the patient is handed to the patient, and twice a year we whip that out and do what we call a powwow.
Okay. So this is great. So this is very comprehensive. Obviously, you're right out of the gates. You're sort of getting all the ends,
laying it all out.
Yeah, you're putting it all on the table and say, here it is, and this is what we're going to do, and this is where we're going.
Yes.
Okay. So we know that these diseases, many of them there's a lot of overlap, and there's a lot of influence, things that can influence the disease, ethnicity, lifestyle, etc. So let's talk about starting to differentiate some of these diseases. Let's say in your first visits, in this comprehensive workup, are you moving right to biopsy? Do you like to go with your clinical diagnosis and treat, and then maybe biopsy? How do you approach it?
Yeah, I think I'm a dinosaur. I'm one of the last people that still biopsy frequently. So the second visit is a biopsy. So that means the first visit, all the questions are answered. The patient is allowed to tell their full story. The second visit is the biopsy, generally. There are some cases where I don't need to biopsy, but I think at least 80–90% of the time, there's a biopsy. One reason is, for example, early stages of CCCA really does, to me, look like androgenetic alopecia. And for every classic case of a particular diagnosis, I probably have a few pictures I can show you where it's a different diagnosis.
Right, and I think that's largely because early on, a lack of symptomatology.
Especially.
Right, exam findings can be there, small, slight, but there's a lack of symptomatology that perhaps the patient doesn't notice it, doesn't think much of it, and then there's disease progression in that.
And there's a lot of patients that have more than one form of hair loss.
Right.
A lot.
Right, okay.
And so that helps me to be in the right lane from the jump.
Right.
Opposed to when we hit a brick wall, if I didn't do a biopsy, we're second guessing ourselves. Right. But if I have that biopsy and we hit a brick wall, we know we just need to step up our game and we can move forward.
Absolutely. So you do your biopsy, and sometimes the biopsy is not necessarily hugely reliable. It's part of the picture. It's one data point. So let's say you get your biopsy, you're confident with your diagnoses. So we have this broad array of diseases. Talk about some of the pitfalls of creating a therapeutic regimen and then knowing when to stop, when to change, etc.?
Absolutely.
Yeah.
So the biggest pitfall is who the dermatopathologist is.
Okay.
So if your dermpath does not like hair, then maybe just use your clinical judgment and not do a biopsy. But then after that, what can happen is maybe your treatment wasn't aggressive enough. So every single visit, if it's say CCCA, I ask the patients very in a detailed way about their symptoms, to the point where patients know I'm going to ask and sometimes will tell me. But I basically ask, I'm using CCC as an example, since I last saw you, have you had any itching, burning, tenderness, soreness, or outright pain? Every visit. We also use measurements that check hair density. That's because I don't want to wait until I can see that the CCCA is spreading, or I see that the female pattern hair loss is spreading, before we step it up. So we do hair density checks that can tell us very early on if they're getting better or if they're getting worse.
And is that photography or?
So we do photography, but the truth of the matter is photography tells you what happened after it already happened.
Gotcha.
Right? By the time the photography shows you they're getting better, you all had a sense you were getting better, or vice versa.
Okay.
So when the hair density decreases by 2%, you cannot see that. Whereas there's a lot of advanced technology that can tell you early on if the diameter of the hair shafts on average are decreasing before you can see that's the case, or if the number of follicles have decreased.
And can you expound a little bit on these, how you are checking density, the devices and methodologies?
Yes, so we have two devices. One is a very simple, straightforward one called the hair check. And you just clamp something on the hair and it calculates the density and you compare it to another area. That's the measurement tool that the stylist in our salon, in our office, has, and she uses that. The one that we use uses artificial intelligence. To the patient, it just feels like we're taking photos. Those photos are uploaded to a software program that uses AI to calculate the diameter of the hair, the number of follicles per centimeter, and after the patient has had two, then it can tell me they're 3.2% better on the right and 5.6% worse on the left.
It's making a intelligent comparison.
Objective, yeah.
Right. That's fantastic. I personally never heard of this, so this is really cool stuff. Okay, so we've got these. You have these diagnostic tools. You've got the biopsy, therapeutics. Okay, because this is where these things get confusing because you treat, and a lot of times, again, we're objectively examining these people for improvement, and it becomes unclear. Sometimes it's not clear where to stop. Is it getting better? Is it burned out? You know,
Yes.
How do you work through this?
So the goal is for the patient to get better, right? But I think the mistake that a lot of us make is once we've done this active phase, for some people it's 3 months, for us it's 6 months, then we just kind of cookie cutter and have the patient, we'll see you twice a year. But that's not the case because the patient can flare again. So generally, the best case scenario, we're seeing someone twice a year, but a lot of times we're seeing them 3 or 4 times a year. That's one part of it. The other part is the stylist, right? When they're doing well, they're checking in with the stylist, and she will grab me out of the hall if it's not the case.
That is so cool.
It is.
Yeah, that's really, so you've got another pair of eyes that are just objectively helping you.
Another pair of eyes is a better way to say. I used to say I have a snitch, but yes, another pair of eyes is what I'll use.
If we want to talk street, we can start talking street if you want. But okay, that's great. That's fantastic. So let's get a little bit more specific. Let's say you've been treating LPP. Any of these. Let's say LPP.
Sure.
And you're treating, and okay, they're on whichever flavor of medicine you want to use. And you feel like objectively that, okay, it doesn't look like the hair loss is progressing. Do you biopsy at that point? Let's make sure it looks burned out. Or if we see it's active, we keep going. Is there a solid approach to this?
Yeah. So as much of a fan I am of biopsies, I try my best to never have to do it again. I use it to make sure I know which direction to take. So generally, what we do is once the patient is better, we wait to see that they are symptom-free for at least 3 months.
Okay.
And then we do things, we ask the patient, are you happy with where you are, right? Did we reach the finish line? If so, then they're always on maintenance, right? Until I have a cure, until somebody invents a cure, the patient is always on something. So for LPP, for example, they always are on some anti-inflammatory pill. I tend to use hydroxychloroquine. Dinosaur, I'm one of the few that still uses it.
No, I'm with you. I'm actually I'm more comfortable using something like that than methotrexate personally.
Absolutely.
Yeah. So
Absolutely.
I mean, I get it.
They're always
I'm
on
with you.
something.
Come on, we're not that old.
We're not, okay, good,
we're
good,
not
good.
too- Okay, yeah.
And then they always have a PRN if they feel symptoms, right? And again, I'm always checking when I see them if they're having symptoms. Then if they're symptom-free for a few months and the patient wants to, then we'll look at what we call repair, whether it's PRP, PRFM, hydrodermabrasion growth factors, et cetera. Now, the results of those type of treatments for AGA are wonderful. Not as good as with LPP, but the LPP patients still deserve it as well,
Sure.
right? And just set expectations.
Right, exactly. And then maybe the therapies, it's sort of a situation where you know it won't hurt, and you can probably only help with supportive hair things in general.
And if anything else, they tend to stay under control a bit longer with those modalities.
Right, okay, that's great. And this is, again, you mentioned a whole slew of things in there that are great. We know that some of them might be anecdotal. There's not necessarily a ton of data, but you know, we know that they're used, for instance, like PRP you mentioned.
Yeah.
How often are you using something like PRP in, let's say, any hair loss condition? But let's say in any inflammatory hair loss condition.
All the time. We probably do maybe 5 to 10 cases a week, but I really have an abnormal high number of hair loss patients. Every day is at least 60% hair loss.
Okay.
And I've had these patients for years, so I have a ton of patients where they're controlled. So some of them are just coming in for maintenance, and for me, maintenance is at least twice a year.
Okay.
Or they're in their active phase, which is 2 or 3, 3 to 6 treatments in a series. So quite regularly, but only after their inflammation is under control. And I always wait at least 6 months before we're even talking about PRP or PRFM or something like that. And then some patients will have a flare when we're in the maintenance phase. And what I do is their PRP can usually still be every 6 months, but then there's an interlusional triamcinolone session in between.
Okay. So to wrap up the discussion on therapeutics, when do you change therapeutics? This is a difficult thing too in these diseases because there's really, if you think across these diseases, there's rarely any silver bullet medicine,
Yes.
right? There's a slew of things you can try, and they're all sort of, you know, might not work. So you're going to start somewhere, and at some point, where do you? It might differ from therapy to therapy. Where do you start drawing lines and say, we got to jump ship? Let's jump on another ship.
Yeah. So combination is the name of the game. I'm usually adding 2.
Okay.
So, for example, our category of grow. For mild cases, some hair supplement plus an anti-seborrheic shampoo. For some people, that's sufficient, right? But then when we hit that brick wall, the patient already knows on that sheet if it's AGA. Do you want to add spironolactone? Remember, these are the pros and cons. Do you want to add minoxidil? These are the pros and cons.
Right.
I usually don't do oral spironolactone for anything other than AGA at this time.
Got it.
Same thing for everything else. Let's say inflammatory diseases. I tend to use the combination of dutasteride and hydroxychloroquine for FFA and LPP. CCCA, I'm a huge fan of JAK inhibitors, actually, for CCCA if I can get it covered.
Okay, yeah, that's interesting, yeah.
Yeah, so I usually start with doxy, hit a brick wall. Maybe we're grabbing hydroxychloroquine or a JAK inhibitor if we need to.
So therapeutic options, you know, you just mentioned some of them, and there's just a compendium of things, right? Because we already mentioned that there's a bunch of them, nothing's a magic bullet. But you did mention JAK inhibitors, so I want let's touch on that a little bit because I know a lot of people are curious about the use of JAKs in these in alopecia disorders. So why don't you talk about that a little bit? What the background of that is, what the evidence is, so forth.
So JAK inhibitors are indeed great for alopecia areata, incredibly helpful for severe cases. But I am a huge fan of using it for CCCA, central centrifugal superficial alopecia. I had a patient where everything we did just did not seem to get her symptoms under control. A beautiful young lady in her 30s, scalp feels like it's just burning all the time and a lot of shedding. And she had failed hydroxychloroquine, doxycycline, injections, everything. And since I knew the MOA of JAK inhibitors, I approached her with trying it. And I kid you not, a month later, she still had shedding, but her symptoms were gone. And then the next month, the shedding had stopped. And considering I had already tried everything in her and for her to have relief for her symptoms, I started to use JAK inhibitors in other patients that had severe active CCCA, and I was seeing pretty consistent results with the inflammation.
Well, that's fantastic because we could use as much help as we can in that condition for sure. So, what does the literature say about this? Is there much out there? Probably not.
I know. I'm one of
Are
those.
you gunslinging out there?
Exactly.
Yeah.
I feel like I am, and so thankfully, there's a lot of people who do stop, take the time to do the research, write it up, etc. Whereas I just kind of tell people and hope somebody writes it up.
Oh, I don't know. I think we might have to lean on you for a paper here. So, well, that's great. I mean, it makes sense. And what we know that these medications do, the pathways they affect and the diseases that they help, it sort of makes sense in the inflammatory realm. So that's fantastic. So why don't we do this? We've talked about therapeutics, and I really want to talk about your practice because, again, this is such a great concept. I'll let you just run with it. Tell us about what you're doing. You have this unique marriage of a cosmetic salon type situation combined with a medical practice. This is fantastic. Tell us about it.
I highly recommend it for all the hair geeks out there. So in our practice is a full service hair salon, and it doesn't have to be fancy. We just turned one of the exam rooms into a salon. So it's similar to the current practice of a salon suite.
Okay.
And the workflow is the patient comes to the front desk, and they'll say that they're here to see Susan Peterkin or the stylist, and she goes straight into the salon. And the stylist will wash the hair, do a steam treatment, blow dry, what have you. The patient then comes to, across the hall to our exam room, and we do whatever treatment that she's scheduled for. Then she goes back to the salon, and the stylist styles the hair. What's good about it being in an exam room is for patients who feel really self-conscious and vulnerable about their hair loss, they just close the door.
Right.
And they have privacy.
Yeah.
And it also allows for the stylist to shadow me from time to time. It's made her a better stylist. And something I always say is patients lie to us all the time, and they tell the stylist the truth.
Yeah.
So very quickly, I'm able to tell if patients like a treatment, hate a treatment, if it's working, if it's not working. When we get a new product, usually companies will give us products for me to try on me. I turn around and I hand it right to the stylist. And by the end of the week, we've had 20 different people that have tried it. So we know very quickly how much we like or don't like the product.
Right, you're getting some like immediate empirical feedback to what's going on. Well, that's such a great concept, and I understand this has got to be the only dermatology practice that's doing this.
So not anymore. So we built it in 2017, and last I counted, there are 5 other dermatologists that also have a salon in their practice.
Okay, well, you're the pioneer, so they need to put your name on that somehow. Well, that is amazing. So we could talk a long time about hair loss disorders, alopecia disorders. So let's do this. Let's end with a little bit of rapid fire where I can just bounce some things off of you. You can give me some answers, something that people can digest in small bits here. And I think that what might be useful because of the diagnostic issues people have sometimes, let me throw you a disease state, an alopecia disease state, and I want you to give me back your quick answer on how to differentiate it. What's something diagnostic of the condition, whether it's exam or histopathology, something like that. Okay?
Yes.
All right. So let's start with androgenic alopecia.
Very straightforward, especially if they have straight hair. However, especially if it's a Black person, biopsy.
Biopsy, okay. So you mentioned you biopsy 95% of your patients. Okay, so then telogen effluvium.
Usually the hair pull test will still be positive, even if they comb their hair that day, but the history
All right.
actually tells you.
Okay, history. And then real quickly, because the pull test, it requires some quantification,
Yes.
you know, so just explain it real quick.
Very quickly, crude way to do it. If 10% of the hairs are released when you gently pull it, it's usually normal. More than 20% is definitely positive. Between 10 and 20 is kind of iffy.
Okay.
So whether you pull 20 hairs, you can just count those hairs. If you want to pull 100, it's about the size of a straw.
Okay, got it. Okay. And let's go to CCCA.
Well, I do take a history and exam biopsy for sure. I want to know how many follicles are in my biopsy, the degree of inflammation, if there are miniaturized hairs, etc.
Okay. Frontal fibrosing.
Alopecia. Usually the physical exam, but I will still biopsy it because I definitely have cases of traction that look like FFA. And then I have cases of what I thought was FFA, and I'm sorry, what I thought was androgenetic and was FAPD, frontal alopecia and a pattern distribution.
Right. And that is probably something less known to people. So can you explain that?
Yes. Frontal alopecia and a pattern distribution. Even I am burnt on this one, even with a biopsy. And clinically, it'll look like a patient who has FFA, but they respond better than expected to treatment, or someone who clinically looks like androgenetic alopecia, but seems refractory to treatment.
Okay, right. So they're maybe not doing well with topical minoxidil, but they do really well with steroid or oral medication.
Yes.
Right.
Yeah,
Okay.
I do treat with anti-inflammatory measures, intralesional triamcinolone, low-dose doxycycline, antiseptic shampoos, but then also usually oral minoxidil for those cases, or even hydroxychloroquine if I need to.
Okay, then traction alopecia.
Traction alopecia, fringe sign is a nice, clean way to recognize.
Explain that for me, since
Yes,
it sounds to me like this is something that you felt like everybody knew, but maybe
everyone knew.
Okay.
Yeah, I didn't use the term. We didn't use the term fringe sign at Howard when I trained. It was 3 zones, but we did think everyone knew. So you have the original zone of their hairline, a zone of hair loss or alopecia, and then the new hairline.
Okay, got it. Which makes sense in the mechanism of the disease.
Yes.
And what about, let's say, frontal, specifically alopecia areata, frontal alopecia areata versus a traction? Give me some differentiation there in that condition.
Absolutely. So more so than biopsy, I tend to use a dermatoscope if I'm suspicious of alopecia areata, and that's where we're seeing exclamation point hairs, whether it's actual exclamation point hair, elongated hair, black dot, yellow dot, circle hairs, etc. So that almost always will tell me it's AA and not traction. But if I'm not seeing those, the patient's getting a biopsy.
Got it. Okay. Then lastly, social support for these folks. It gets missed because we're so hyper-focused on the physical part of this condition. And we're aware of perhaps their psychosocial status, but there's not a lot of resources that are sort of, let's say, widely known or maybe widely available. Give me your couple slam dunk places where this is a great place to go to get information or a great place to get support.
Yes. So for us, privately in our office, we have a discussion group that's every other month virtually. And the stylist and I lead that discussion group. However, there are certain stylists that are actually also psychologists. It's the most brilliant thing, I think, that we can refer our patients in. We have a few in Maryland where I am.
No kidding.
Yeah, it's great. But I guess stylists are already psychologists. Talk therapy works great. And then there's some Facebook groups actually that are helpful. I think one of the most troubling parts of hair loss is everyone thinks they're alone, right? And just knowing how common it is gives patients relief. What I think we really need to get to is the point where insurance companies stop calling hair loss cosmetic, and that's why the resources aren't so available for these patients. Okay. We have to get that under control.
And if for me as a clinician or any clinician watching this, how do I advocate?
That's so hard. So I would actually, as a dermatologist, send the patient to a psychologist because talk therapy is so incredibly effective. And I would have a go-to stylist that's local to you that you can send their patients to that are sensitive to the vulnerability that comes with hair loss.
Okay, great. Wow, all such great advice. And man, I could sit, I would talk to you for another hour if your plane wasn't leaving. But thank you so much, Dr. Kindred. This was, I really enjoyed speaking with you. And, you know, we're going to bring you back and, you know, try to do this again and get some more information out of you. But thank you so much for sharing your experiences in your insight and especially your unique approaches to treating disorders of alopecia.
And thank you so much for the invitation. This was fun.
Yeah, it was great to have you. Thank you. Thanks for watching Dermcast TV. It's Rob Casquejo in Boston, Mass.